Textbooks categorize diseases by organ system and definitive symptoms. The emergency department is different. You are faced with messy, undifferentiated complaints in high-pressure environments where time is the primary constraint. These moments reveal a specific category of medical error, the fatal resuscitation prime. These events occur when standard protocols are executed correctly, yet without the necessary physiological context. Arriving at the right diagnosis and ordering the correct drug can still be immediately lethal if the sequence of treatment is flawed. We are going to deconstruct 3 clinical scenarios where a standard of care intervention becomes the actual mechanism of death. Survival in acute care depends on treating the shifting physiological reality of the patient, rather than simply matching a diagnosis to an algorithm. Consider a patient with end-stage renal disease who has missed their last 2 dialysis sessions. Their blood is saturated with potassium. This ECG shows how elevated extracellular potassium decreases the resting membrane potential of cardiac myocytes. As the level rises, it progressively paralyzes sodium channels, widening the QRS complex until the heart can no longer conduct electricity. The standard protocol is a 3-step sequence. Stabilize the myocardium with IV calcium, shift the potassium into the cells using insulin and glucose, and then physically excrete it from the body. Consider a different patient, a 34-year-old in acute respiratory failure from Guillain-Barré syndrome, needing an airway. In GBS, autoantibodies destroy the myelin sheath of peripheral nerves. This demyelination triggers a massive upregulation of muscle acetylcholine receptors as the body attempts to maintain communication. The fatal crime occurs when administering the standard depolarizing paralytic, succinylcholine, to secure the airway. Succinylcholine binds to these upregulated receptors and locks them open. The result is an explosive efflux of potassium into the bloodstream. This sudden load induces hyperkalemic cardiac arrest, flattening the heart's rhythm into a terminal sine wave before the first breath is delivered. Failing to account for demyelination converts a routine airway protocol into a lethal membrane trap. In these patients, rocuronium is the mandatory alternative. Our second trap involves a marathon runner who collapses and begins seizing at the finish line. His serum sodium is critically low at 116 millimoles. The instinctive reflex is treating the collapse as dehydration with a rapid 0.9% normal saline infusion. The true physiology is free water excess. Exercise-associated hyponatremia prevents kidneys from excreting water. As serum dilutes, water rushes into neurons, causing swelling. Adding normal saline is dangerous. Kidneys excrete the sodium but retain the water, actively escalating cerebral edema toward herniation. DiRescue requires an immediate 3% hypertonic saline bolus to rapidly pull water out of the brain and back into the vasculaire. While clinicians fear osmotic demyelination syndrome from overcorrection, the 24-hour limit shown here is secondary to the immediate threat of herniation. In the first critical hours, the acute risk of the brain being crushed against the skull supersedes the risk of ODS. In extreme hypotonic states, treating volume without understanding the osmolar gradient actively drowns the brain. Our final scenario is a patient presenting with fever, neck stiffness, and altered mental status, classic bacterial meningitis. While delaying antibiotics is a common error, a more insidious mistake is made during the resuscitation. This trap involves immediately administering bactericidal antibiotics, like ceftriaxone and vancomycin, to clear the infection as fast as possible. These drugs are highly effective. They work by instantly lysing or bursting the bacterial cell walls within the subarachnoid space. When those bacteria burst, they release a massive payload of endotoxins. This triggers an unchecked localized cytokine storm, causing profound cerebral edema and permanent neurological damage, such as deafness. To prevent this, the treatment sequence is absolute. IV dexamethasone must precede or accompany the first antibiotic dose. The steroid acts as a pharmacological shield, establishing itself in the brain before bacteria rupture, preemptively blunting the anticipated inflammatory surge. Destroying the invading pathogen without first disarming the host's inflammatory response turns a biochemical cure into a catastrophic injury. The battlegrounds of acute medicine are defined by fundamental mechanisms: membrane depolarization, osmolar gradients, and inflammatory cascades. These physiological states determine the outcome, regardless of the disease label. Once a drug enters the bloodstream, you have made an irreversible commitment. This is why the algorithmic mindset is a liability. Medicine is not a simple matching game of symptoms to drugs. A high index of suspicion requires you to look for more than hidden killers. You must actively suspect the biochemical domino effects of your own treatments. You must understand your pharmacological tools from physiological first principles. To prevent the fatal resuscitation crime, the modern physician must look past the obvious and treat the dynamic, shifting physiological reality of the patient.